So we have a little time left, and I'd take a comment or two about Scott's presentation, but I'd also take your thoughts at the same time in terms of the one or two kinds of takeaways you have from the entire day. I think we should take Scott's as a starting point in terms of that kind of reflection. So, so what's in order in this section are comments or questions for Scott, but also your reflections, quite frankly, on what you've heard over the course of the day. So, roundtable members, who wants to start? Or should I begin to call on people? Okay. Rima, thank you.
2 takeaways.
Go for it.
I was very moved to thought and reflection and excitement by Winston's presentation. It really gave me a lot of food for thought. And so not only are we witnessing a paradigm shift in terms of moving from the focus, myopic focus on individuals to professionals and institutions, but we're also moving to a greater focus on social determinants and issues of equity, where health literacy can play a very important role. So I think that's one of my takeaways that I really want to give a lot more thought to. And I don't know where. Thank you for provoking that and really making me think. I'll be thinking about that for quite some time. The second is not quite as positive. Is the recognition that we working in this area remain disengaged. We don't know enough about what people want, how people feel. We are not engaged with people in the way that we should. I mean, one of the oldest tenets in the field of health education in public health is that you do rigorous work. You do rigorous formative research. You do rigorous piloting. You engage with members of the intended audience to help identify the problems and help generate the solutions. And we don't seem to be doing that. We highlight every so often an innovative effort or program that did that, but we don't consider that part of our absolute baseline foundation rigor. And we're frighteningly disengaged with the members of the audience that we really think we're doing our work for. So that was a distressing reflection at the end. So those were my 2, one positive and one.
Great. Who else would like to follow Rima's reflection? Go ahead.
Hi, Kim Parson. I'd just like to build on or echo what Rima has said and remind us of what Ruth reminded us of earlier when she said a previous learning was that patients really are the expert, and we have to figure out how to partner with them. And what I've heard throughout the day is that that's where opportunity still lies. I don't know that we really have figured out how to partner with them, or if we've really made the amount of effort that we need to figure out how to partner with them. And so I would propose that that's where the opportunity is in the future, and to move forward and get closer to both health literate population and health literate organizations.
Great, thank you. Okay, Wilma?
Wilma, I've read a little. Starting with Dr. Koh's comments of this morning, I was very appreciative of his presentation involving health literacy and the class standards, especially as we become a country of the majority minority. And I think that the importance of the awareness and of the implementation of these into health and healthcare and social service areas becomes increasingly more important as we evolve in the majority minority. I really appreciated Dr. McAvoy's presentation where he mentioned the meds having different names depending on where that patient comes from. And I'm seeing this as an interpreter and a language access advocate. I see this more and more as I'm on the units and in clinic. So I was appreciative of that comment. And also, too, I think it was a wonderful opportunity to be able to participate with hearing all the history of what's happened and then to date and everything that's been accomplished, because we do need champions. We'll always need champions. And Winston's talk, thank you very, very much. I echo what Rima said about that, moving into more health equity and also to thinking about race, place, and fate. So I take that away, and I thank everyone for all their wonderful words, guidance, and wisdom.
I see one down there. I can't figure out whose it is. Go ahead.
I'm in this funny spot. I can't be seen. I apologize. I've had this a couple times. So I want to go back to comments on being connected and rigorous. I think that's a really important point. And just get back to today's earlier discussion on measures in the context of use and delivery of healthcare is really important. These measures are critical, but the really incredibly important methodological questions are kind of understudied in this field. So we have a couple of basic questions, but we haven't perhaps dug deep enough across the field to understand some of the methodology. So when we think about how we interpret data that has the potential to significantly impact the system, community health, and people's lives, we need to think about not just what we ask, but who we ask, when we ask these questions in the process, where those questions take place, and who's the actual person who does the asking. That's really important to understand. I started to talk about this earlier, and the question didn't get fully understood, and we had so much going on that I don't know that I understood it well, so I'm going to just say again, I think we need to really clearly consider the methods when we assess organizational health literacy. So not just reliability and validity, but also utility, appropriateness, and from the very most basic standpoint, evaluation methods and study designs that reduce bias as we attempt to better understand what we're doing here. I really appreciate the comments on multiple sources of data, but we can't triangulate if we don't actually have a real clear conceptualization of how these things work together and how we frame the meaning. So, thank you.
Bernie?
So I'd also like to start with what Howard Koh started us off with this morning, with his statement that there is an organizational responsibility for health literacy and how to actually promote systems change within organizations and within systems, and actually a culture change within the organization. You've heard me say before that culture eats strategy for lunch. I think we need to really focus on the culture change within the organization and integrate that into what other people are doing, all people are doing within the organization. I think really it's a bottom-up philosophy rather than a top-down philosophy. Also, I like what Winston had to say, and I'm going to repeat it again probably for about the fourth time, that behaviors, social determinants must be addressed to improve health and achieve health equity. I think we have to move, and I think others have said that too, we have to move that conversation to the community. So it's not only the system that understands that, the community has to understand that too.
Rob?
The day crystallized an experience that I've had 9 times in the last 2 years. And I'll have to explain it slightly. Each time I'm talking to a general education-oriented class of undergraduates in a university. And I'm an invited faculty member for the day. And in the middle of the conversation, which is usually about healthcare or health literacy, I stop and ask them, why does the fact that 1 out of 3 or 1 out of 4 persons who do not have health insurance or can't get access to health insurance, how does that affect your life? And no one in the room has yet ever been able to initiate that discussion with me. So I stop and I say, all right, think of it like this for a second. How many of you in the room have had to work a double shift or work on weekends, or you had some sort of work-related experience because that you didn't expect because someone was ill? And I said, and then think of you how, for those of you who repeated, okay, how did that impact your life? And all of a sudden, the whole tenor in the room changes, and the discussion turns from, this discussion usually becomes very lively. I use that as a prelude to ask something else, which to me is the point. And then ask, how many of you have ever had a discussion like this in college? I've never had anybody in the room who's ever discussed that. And I said, who's ever had a discussion like that in high school? if you can remember high school. I've had one person ever say that they've ever had a discussion like that before. To spark the awareness and to spark the discussion about prevention, wellness, health information seeking, the impact of health on individuals and friends and families and neighbors, and that seems to me there is some evidence about this, but again, I'm discussing about personal experience. We need to work with people who want to spark that discussion in K through 12 and in general education, okay, in universities across this country. I realize that we've heard a lot about professional education, professional schools. I obviously agree with that, but I think the job is actually much more significant than that. The other thing that I'll mention is that we heard today about some health community outreach initiatives that are going on in various parts of the country. George, you mentioned some, and I think again that those are a great group for us to partner with in the future. That is very important. I think we get on that train as fast as we possibly can.
Thank you. Winston?
Thank you. And I wanted to specifically thank you, Scott, for coming today. You certainly are one of the pioneers in this work, and I also see certainly Dr. Parker as one of the pioneers, and Cindy's been one of the champions within the federal system, and Michael Posh Orlaw, too. Really great to have you as in our presence in terms of looking back at this work. And I suspect that as much as gratifying the accomplishments have been, there is a lot of restlessness because the train always seems to be a couple of stops in front of us. And I think it has to do with the nature of not only how we define health literacy, but how society is now defining health, and how individuals, consumers, patients frame the question of health for themselves in the 21st century. So the health literacy conversation is only relevant to how people really are starting to relate to the question of wellness and health given the changing parameters. And it's not just a healthcare delivery reform question, it's a much broader question in terms of individuals and their interface with communities and their interface with society. And that's where the restlessness comes. We have to be relevant to that.
Yeah, that's a very wise comment that I'd like to associate myself with. I think, your appreciation for both Scott's remarks, I think, I see in a lot of what you've said, a lot of wisdom in terms of some practical ideas about how we can move forward. And I see also a call for us to be thinking perhaps through the vehicle of a new report, making more contemporary some of the notions that we've had in the past along the lines of what Winston is saying. And I really like your pointing out the fact that we ought to be putting a lot of what we're thinking about in the context of again, what does a good day mean for those people we're working with. And we've heard consistently over the day the Howard Coe comment about the fact that this is moving to a broader issue than just health care to health. He made that point rather clearly. And he crystallized, obviously, the comment that's made consistently throughout the presentations, including in Scott's presentation, about the complexity and the fact that it's a systems issue. And so we've learned a lot. It's time for us to, I think, gather our thoughts again about those topics in a very accessible and thoughtful and kind of way. So, Winston, thank you for that comment, and I just want to interject in the flow there and associate myself with your wisdom there. Right over here, we've got a card up right over here. Yeah, Lori's.
Thank you. And thanks for a great day, and to all the planning committee as well. I wanted to reinforce something that Betsy had actually said, which is that health literacy will advance when it's integrated and part of other important things. And that really stuck with me. And one of the things I thought about, something I've been working on, is clinical trials. And Terry from the FDA started the day by talking about one of the elements of PMI could be sharing information on subgroup demographics, whether it's safety and efficacy. And if you think about that, in order to do that, we need to have better representation of minority patients in clinical trials. So this is an example of where the themes from today, I think, come together. So the first thing is we need to ask patients about clinical trials and their perspective and what are the things that are important to them. I think we need to train minority serving investigators, not just minority investigators, obviously are important. We've actually been doing a pilot around cultural competence and teach back, and it has been incredibly well received. I think we need to educate pharma companies on a more, we're starting to get there in terms of the recognition of the things that Winston talked about place and social determinants that are relevant to participation. And then finally, I think we need to think about, with clinical trials, applying health literacy principles. So whether that's informed consent, whether that's patient diaries in the clinical trials, whether that's lay summaries to participants who have participated, and ultimately, that all comes together in the patient labeling. So I just see something like that as just an area of great opportunity for our field, which really will impact patient health. And the second point I wanted to make is we need to expand the conversation. And I think Dr. Wolf earlier said, the base is shrinking. And I know I've gone for the last 4 years now, I guess, to the IHA and to Health Literacy Research Conference and IOM, and it's the same faces, and they're wonderful faces, and I love them. But we need to expand the conversation beyond that, invite others to the table. And I think one of the ways to do that actually might be, the book on numeracy is a great example. The IOM report was fabulous. But when people ask, okay, how do I do this? And you direct them to the book, they don't do it. And so I wonder if moving forward, we could think about, with clear communication principles, how do we take the wonderful knowledge in this room and create cheat sheets on numeracy, or create things for people who want to do it but simply don't have the time to invest in learning everything. So thank you.
Yeah, good comment. I think, Betsy, you're next.
I just wanted to follow up on your comment. I heard Ruth brought up something this morning which I really agree with, which is, can we build into the late-stage clinical trials the information or the exactly how the patient is going to take it, and actually find out whether we have, with the intervention, we have actually come up with something that will help the patient for whom it is a good intervention to actually take it. And I do think that would be a very good thing, and it would be a good thing to be a normal part of most late-stage trials.
I think Michael's next. Is it? I can't quite see the cards with this angle. So
Okay, I'll be brief.
Okay.
So kind of as an incorrigible optimist, I have been for the past 10 years, seeing where we've been and where we're going to, I am actually very heartened by the way the medical model has kind of been flipped from the healthcare system being the source of information, and patients needed to come to us, and if they couldn't, then that was the steep slope they had to climb up to. We're starting to do more listening and trying to bring our expertise and our ears and our empathy back down to them, and trying to level out that playing field with the passage of the Affordable Care Act and more people coming into the healthcare system. I think there's more opportunities for us to be able to extend ourselves out and to do a lot more listening. And the trend of technology and healthcare, I think, is only an opportunity for us. Dr. Koh this morning mentioned barriers as just being opportunities in disguise, and I think that's a very, very apropos comment. Health literacy, I think, is becoming much more required and much less optional these days. I think the conversations are continuing around that, and those are very critical conversations. On our health literacy community listserv, we've had some conversations last week about research being disseminated more greatly or more effectively into practice, and practice informing research on the front end. So I think that's a very critical conversation that needs to continue to happen. But I think we have a great opportunity with more people coming into the healthcare system who have never had health insurance before to allow them to become full healthcare citizens and really take full advantage of that right.
Thank you. Lori?
I'd also like to comment on the clinical trial experience, sort of linking our last conversation from July to moving it forward and building on what Lori Myers has mentioned. It's interesting, and maybe many folks don't appreciate the extent by which pharmaceutical companies are really trying to do a better job of listening. And one of the ways we're doing that, I will paraphrase something that I recently heard from a colleague of mine who's in the clinical development innovation space. So looking at clinical trials in a new way, in a transformative way. And he said something very powerful. He said, in the past, in research, we've often treated our volunteers as raw materials in a supply chain process. And we've got to think about this very differently. And in fact, not only do we need to involve patients sooner, but perhaps involve these volunteers in the design protocol. Help us understand. You are the experts of you. And we're taking that very seriously to the extent that we're looking at ways to honor patients, honor those volunteers who've helped us learn more through the clinical trial experience. And part of that honoring comes with keeping them engaged along the process. It comes back to communication. It comes back to here's where we are in the process. Here's how you're helping us learn about what's important. Here's how you're helping us understand the process. So it's ongoing communication. It's honoring them at the end of a study, whether it was successful or not, but closing that communication gap to know where we are and what the result is. Perhaps you helped us bring a very important medication to market that is helping, a myriad of patients who didn't have a treatment option in the past. So we're looking at this in a very different way. And I say this only to make the point that we've heard a number of conversations today about looking for research funding and partnerships, and we've even heard a bit about commercial bias. And please understand that in my industry anyway, we really want to be and take this very seriously, being a part of the conversation and having a seat at the table, and that oftentimes we're still having to overcome some age-old perceptions about pharmaceutical companies being a sales and marketing organization and not much more than that. But please understand that couldn't be farther from the truth. We really are evolving, and understand that pharma is a collection of scientists and hundreds of physicians and nurses and pharmacists who are coming together. We have nothing to do with sales and marketing and everything to do with making a difference for patients. And we really are very much motivated by this concept of shared value, that there are things that business can help, resources that businesses can help bring to the table, along with government and advocacy and academia, to solve these big, important social issues. Just wanted to say that. Thank you.
Great, thank you. Ruth, I think yours is next, and then Lindsay, and then back to Andrew, I think.
So I'm going to echo the 10 out of 10 for Winston. That's all I'm going to say about that, Winston, 10 out of 10. So Scott, number one, where's the beer? Okay. So, it's beer time, and you can fill in the rest. Okay, so that's the first comment. Number two, there are some of us who know that you were certainly one of the little engines that helped make the first report come out. And I think there's a lot of gratitude from a lot of people that happened. And there are a lot of people in this room who know a lot more about what it takes to make an IOM report happen. But I do know it takes good ideas and it takes sponsors. So here's my question. So you got up here on the top, this new IOM report on health literacy with recommendations of integrating a new health system using new technology. So I wanted to push a little bit and say, one of the thoughts I had today was that maybe we're into another generation with technology. We have had so much language as technology became, as we all had our chips embedded within us in whatever way that we're now so connected to. I mean, like, I wasn't nearly as connected, none of us were when that came out, as we are now. And I'm wondering about, and we spoke then, and we continue to speak about increasing complexity with technology. And I'm wondering about simplicity and technology, and whether or not, oh, I like the funders nodding. You don't know how good that makes me feel. So here's my question. Like, you know, you live in Princeton, and Einstein, you know, he said, he lived there, you know. He said, make it as simple as you can, not simpler. That's pretty brilliant, because simplicity is brilliant. It's really difficult, and it's an art and a science. And so I'm wondering about technology and simplicity and health or health care, and what your thoughts are on whether or not that's fundable for an IOM report.
Please. Scott?
Well, that's it's obviously a difficult question of guessing the future of funding mechanisms. So I'll stay away from that, but I think you've hit on, I think, the importance of the area. And when we've talked about checklists and scorecards, and it's been with Michael, your group, with Atulga one day and some of his folks when I was working on this globally, we noticed that all checklists and scorecards and these algorithms are aimed at the learned intermediary. The safe surgery checklist, the central venous catheter, all the pieces that have made a huge difference in delivery of care and lowering what we're trying to even get away from the term errors or accidents, because they're preventable, they're simple if you put in the right protocol. So how can we get that to the consumer? And private sector companies that have brought these technologies to us have all tried to figure out ways to get into the home. The Xbox is not just there. Again, I have boys, right? So they're there learning about FIFA and everything else, but that's largely Microsoft's way into the house directly. Other companies to figure out other ways to get these mechanisms into places, and now this whole Internet of Things. Each of these big companies are starting to think about, how do we get a piece of the health pie? I mean, let's face it, it's 17% of GDP, everybody cares about it, common currency. So my piece would be to suggest, and I've said this at the mHealth Summit and the other pieces that are led largely by the technology guys, we have to get the health people leading where the technology ought to be, not the other way around. So I'm flipping it back, Ruth. The funders around the table are not necessarily private sector or tech-related groups. Maybe they're more difficult to get than others. Agencies can certainly look at it when, you know, as I look at Betsy, because I know from Medline to Medline Plus to the other ways of what their mission is. FDA had in their public health mission, has public health in their mission. You know, there's lots of other places that are there. So I think it's a multi-sectoral opportunity. And if you perhaps took this to one particular level of what is that area, whether it's infectious disease, you know, pick something that has large impact for all sorts of players. That would be my suggestion. Not just a theoretical piece. I think the last pieces have been quite helpful. The quality reports were a whole series, including the report card and other pieces that were there. I mean, Cindy would know better than anyone of what's made, you know, all of this stuff happen. So I don't know if that answered it well enough. I'm just a believer that we can't keep aiming everything at the learned intermediary. And we have to figure out how to get to the individual with information they can use in a simple way. And I think it's likened to the Gutenberg press. It's not like when we had, 8% of the world's population was illiterate in reading at that time. You know, the movable press made a huge difference just for people to start to read. You know, if you think, I think it was 98, I was on the interactive panel on science communication and health, which was an HHS. If Linda were here, she may know about it. And we wrote about the digital divide, and we had all these pieces published. And it's still, to this day, the digital divide was there on the internet. But this thing has changed it. So I think the simple opportunities are there. And I think everybody's got a piece in this, so it should be something that could be funded.
Very, very good question and a good answer too. And without taking away from that answer, I'd add another of my own points. In the exchange with Michael Wolf on the panel around research, it seems to me that in order to get to simplicity, one needs to understand in our society the causes of complexity at a bit more robust level, which is a bit more of an academic piece. But it seems to me that there's a combination of opportunities that in terms of dealing with that has some recipe that involves policy, initiative in the private sector, rules and common understandings about how complex systems work, that if we really believe that health literacy is a function of skills and ability interacting with complexity and the interface of complexity, we need to understand that. This field needs to understand that much more profoundly so that it can come to solutions around how to deal with it. And a research agenda needs to generate around that. So I think, Lindsay, you're next.
Yes, thank you very much. It's just been such a thought-provoking day, and thanks for the opportunity to add oral health to the conversation. Following on the conversation we just had about simplicity, I mean, in terms of preventing oral disease, dental disease, we pretty much know how to do it. We know how to do it, and it's simple. It is simple, but implementing that, getting the word out is so difficult, and that's where we really have to pay attention to the social determinants, so I really appreciate the conversation earlier that we had about that, Winston's comments, George, your comments about moving the conversation more broadly into population-based health and weaving health literacy, a theme in a cross-cutting way across all the determinants, environment, healthcare system, communities, schools, community agencies, in order to support the community and people's self-management ability. But that takes a lot of social and political will, as somebody else pointed out. So at the end of the day, my head is kind of exploding around that. One other thing I wanted to mention was what Dr. Coe said this morning about making a business case. And George, you mentioned about moving beyond the cycle of costly crisis care, and this is definitely true in terms of government funding for dental care. It's not required for adult benefits to be offered under Medicaid. Most states don't do it. In fact, during the recession, many states eliminated funding for adult benefits, and what we saw was an increase in using the emergency department during, there was a report done that came out in JADA just recently. Between 2008 and 2010, more than 4 million people used the emergency department at a cost of $2.7 billion, and they received only palliative care, antibiotics and pain meds. 40% of these people were uninsured, and 60% were not. 60% had insurance, yet they couldn't access care, or they didn't know how to use their insurance. So I think there's a huge opportunity in terms of health literacy, improving those statistics. So those are my thoughts, and again, thank you. Thank you for
So we're a little over, but we've got a couple of more comments to go here. I think, let's see, right here, Marion, and then down to Andrew, and then over to Steve.
Just a few quick thoughts, and first I want to say it's a real honor to be here, and more than that, it's a joy. It's been so nice to know so many of you for so long, and to be here and hearing the progress is really inspiring. Winston, you were clearly a touchstone for this meeting, and one of the things that I would love to see is a 360 operationalization of what is equity, so that we don't build it piece by piece, but take a look at the entire process in terms of equity. And also that the race question always seems to end up at the end of the discussion. Maybe it's when people are sort of more comfortable, but that's something that we really need to grapple with in terms of how we define our relationships and our contexts. I think that it's really nice to know that the hierarchy model that 100 years after Flexner Plus is being flipped on its ear, but at the same time, we've got to look at who's going to be bringing our primary physicians in that growing group of folks who are being clustered in the new system to that, and look for what I would suggest is hierarchy creep. In that when we were talking about support services, they were support instead of core services. And as long as we keep thinking about the communications and health literacy aspect as a nice add-on, then it doesn't become hardwired to the process. And I think there's an opportunity to look at the complexity of risk. I know many people in this room have written very intelligently and wonderfully on it, but we've looked at it mostly in terms of numbers and how to explain them instead of the emotion of risk. And I think risk and fate happens and trust are all intertwined in a way that we kind of haven't looked at those three constructs together at the same place. And I bring one good piece of news, and Michael will have to add the name of the young physician, but I heard a young physician, this is good news, because this was a very young physician from Michigan and the University of Chicago, who just did a really smart study on inhaler use that looked at the system as well as the process, as well as having a very full picture of it. So I think there's hope for the future, particularly in the training end.
It's always good to end with hope. Okay. Is that Andrew? Is that your card down there?
All right. Hi. I'm not going to be long. I don't want to get between you and your opportunity to advance Scott's career. Oh, come on. That's all right. Don't worry about it. Scott heard me. I'm going to pile on, Winston, but I heard it a little differently. I want to say thanks for embracing the need to address complexity in actionable ways and work in the reality of people's lives versus condoning that as a barrier to improving health and advancing health equity. We don't hear that enough. A quick side note, just because I heard this, but not a lot, but there were a few times during the day when there were some demeaning and sort of ridiculing words about various segments of the population because of things they couldn't do still. We really need to get away from blaming people. From a health literacy and equity perspective, it's always important to respect all people, no matter how much you might disagree with their perspective on health and healthcare. It would be a barrier to helping them help themselves be healthier. A little ad, because despite the somewhat gloomy outlook on technology we heard from time to time, please do remember that on March 24th, we will be having a roundtable meeting looking at health literacy, new technology, and health, and hopefully we'll be able to present some really productive and illustrative case studies of how things can work. And finally, I just want to say it's always nice to be, in my view, part of a field that is trying to address needs and create true equity as a means to put ourselves out of work. Prevention, in my view, has to be a significant part of that effort. I think it was probably a bit underserved throughout the day, but I'll just close by saying that I hope in 10 years from today, we're all unemployed. Thank you.
Okay, Steve.
Thank you. And I'd like to thank the Planning Committee for a great program. I'd like to thank the staff, and I'd like to thank the presenters. I also would like to thank what Malcolm Gladwell calls the mavens. And there are a lot of people in the room who've been doing this for a long time. And I'm really excited about seeing the change from where we were to where we are now, and then beginning to take a look at where we could be. I'm very excited to see how we might move from awareness to social and behavior change in individuals and organizations. I think that's a really big piece. And some good things came out today in terms of creating the case for change, particularly in organizations, and particularly in organizations that have a big influence in how healthcare is provided in the future. And lots of takeaways. Thank you very much.
Cindy, I guess you're the last note.
Thanks. I have to say I was surprised, and it was a little strange to hear so much today about social determinants of health. I actually came from that world. I used to work in poverty and welfare. I ran a housing program for homeless families. I helped welfare recipients get training. And that's not what I think about when I've been doing this work on health literacy. So the last 18 years I've been at ARC, and for me it's been about fixing a broken system. And back in 2010, I think we were on a bit of a high. We asked, are we at a tipping point? We had health literacy in the ACA, we had the Plain Writing Act, we had the National Action Plan to improve health literacy, and it really seemed like, we might be, finally have that momentum and be able to push it over. And 4 years later, I don't feel like we're there, and I, in some level, really wonder why. I mean, I think that if we ask anybody, is it important for patients to understand communication from their healthcare system? Is it important for individuals to understand what to do to stay healthy? It's a no-brainer that that we, would all say yes, and yet we still are fighting, slogging, the Chinese water torture of trying to drag organizations to address this issue. And while I absolutely agree with Bernie that culture eats strategy for lunch or breakfast, depending on who you're quoting, you can't start with culture change. And so the question for me has always been, what have been the levers to do the change of what we're talking about, perhaps having paradigm shifts? And so in my work in this area, we've looked at tools like the Health Literacy Universal Precautions Toolkit. We've looked at education, so creating CME and maintenance of certification education. We've looked at creating vision, whether that be the National Action Plan or the 10 attributes of a health literate organization, of what could this look like. And for me, when Mike was talking to me about the Russian dolls and health literacy being nested, I said, well, I've always approached this more as catch the moving train. Some people have been very visionary and said, we need to link health literacy and cultural competence to patient safety, because that is what everyone's paying attention to. That there's some very, I'm opportunistic, and let's seize those opportunities. So for me, I see health literacy writ all over the talk of patient-centered care, of self-management, of shared decision-making. And I approach this very much as a consumer, and Don Berwick popularized nothing about me without me, that is sort of the hallmark cry of health literacy. And Michael Pajorlo said, what should we do with our educational privilege? And I think we have to recognize that the people in power do have educational privilege. And my experience is when you talk about health literacy as a vulnerable population that we have to take care of, you get less traction. And that health literacy, at least in my experience, has really sailed when it's about me, my grandmother, all of us who want to understand, who don't want a complex system that makes it hard. And so when I'm thinking about what are our next opportunities, Andrew mentioned what our next workshop is, but we also have a workshop in the wings around sort of palliative care and end-of-life care, because we are all going to die, and our loved ones are going to die, and maybe that's the next area. I know I'm being really heavy at the end of this, but that's where I'm at right now. That may be our next opportunity to think, how are we going to push this forward?
Very good comment, Cindy. The other thing I'd say, just again to reflect further on yours before we close, you know, a lot of very key stuff has happened within the federal government over the last decade on this topic, and at the IOM and other places. But it's ahead of society at this point. And I think that Howard Koh this morning was right on target when he said that the conversation needs to move more broadly into health, which is the echo theme that's been restated over the course of the day. And we've heard so much about it today because I think that notion is at a tipping point. I know that from the other roundtable and from other things that are going on outside of health literacy. It's when that comes back and is married with the trend that he talked about in terms of this being moving from an individual issue to a systems issue, and the incentives in place in the Affordable Care Act and other transformations that are occurring in healthcare delivery. It's those combination of events that then create the opportunity for the culture and the rest of the system to follow. It just takes a good long time. So I think there's a real lot of opportunity coming up for us to be contemplate in terms of where the next steps are for health literacy, and we've heard a lot of them over the course of the day. Scott, I want to thank you in particular for just an outstanding job of giving us something to think about in terms of those next steps. I'd like to thank all of the speakers for taking their time for preparing, and the panel moderators, even the Something Different panel, which I thought was very good. I want to make sure that I thank the Planning Committee once again. You know who you are, and I've lost my list of you, so I won't name you again. I want to make sure that I take the time to thank the members of the Roundtable for their contributions and thoughtful comments here at the end of the day and throughout the day and their questions. IOM staff, Lila, you're just terrific in terms of but Melissa has courage in terms of making sure she's showing those signs and all the other help that she's given. Drew on the web, and Angela, really appreciate that. And of course, we have to always acknowledge Rose when she's in the room, because she's the big chief that really gives direction to this. Thank you, IOM staff. Really, we can't engage in this important work without that kind of professional approach. So with that, I think I've thanked everybody. I think we're adjourned. So thank you very much.